Hello, my name is Philip Meese, Director of Rheumatology Research at Providence Swedish Medical Center in Seattle, and I'm joined today by my esteemed colleagues, Alice Gottlieb and Mark Lebwall. We're going to be discussing the challenges of diagnosing and treating psoriasis and psoriatic arthritis. These are the modules that we'll be going through: early detection and diagnosis, personalized and accessible treatments, and then comprehensive multidisciplinary care, underlining the point that it really takes a village to manage a patient with this complex set of manifestations in the skin and musculoskeletal features. Just to set the stage about the frequency with which we see psoriasis and psoriatic arthritis, we know from a well-done NHANES survey that psoriasis occurs in 3.2% of the US population. We estimate that in various series of psoriasis patients that up to 30% of these patients may have psoriatic arthritis. This particular graph indicates that typically psoriasis begins first, and then psoriatic arthritis starts later, on average about 10 years. And it's gradually we see more and more patients manifesting the inflammatory arthritis, the enthesitis, where tendons and ligaments are inserting into bone and are inflamed, or in the spine, in addition to the terrible skin and nail changes that can occur and which will be spoken to more by Alice and Mark. I alluded to the fact that usually psoriasis is the first thing to appear, but sometimes the musculoskeletal manifestations will occur at the same time, or we may even see musculoskeletal features begin the disease process, and psoriasis will join later. So let's focus down on how you go about diagnosing and then treating in a customized way for the individual patient. So I often like to show this photographic montage of the features of psoriasis and psoriatic arthritis, which really gets across the point that patients can present with many different clinical domains. On the upper left, we see the terrible ravage of skin manifestations of psoriasis with erythematous, elevated and scaly lesions on the skin, and just below that on the patient's legs. This is just a horrible illness to live with. Below that and to the left are changes in the patient's nails. So anyone working in the public domain is often embarrassed, even if they can cover up other parts of their skin. They may have significant changes in their nails or flaking in the scalp. And then as we move to the right, we start to see some of the musculoskeletal features, including on the top, inflammatory arthritis with swollen joints in this patient's hands. And just to the right of that, a time-lapse sequence photograph of an X-ray of fingers showing progressive destructive changes in the distal interphalangeal joint. Just below that, we see the fat sausage digits of dactylitis, and to the left of that, the enthesophytes of the patient's heel representing enthesitis. In the upper right and right side of the slide, we see changes that are going on in the spine as a result of inflammation there. And in the very bottom, we see some of the associated conditions such as inflammatory bowel disease, uveitis, and then this poor woman who is obese and likely has hypertension and underlying cardiovascular disease. This is the metabolic syndrome that is often a feature of patients with psoriatic arthritis and psoriasis. It's a complex pathophysiology, and over on the left, we're showing a dendritic cell that may be at an interface like the skin or the gut lumen that is perceiving a danger signal, such as an alteration in the gut microbiome or trauma to the skin surface or some other stimulus that is getting the cell to be activated and to pour out various inflammatory cytokines, including interleukin 23, interleukin 22, and others that lead to signaling to a variety of different immune cells and effector cells via cytokines such as TNF, interleukin 17, interleukin 23, and these then effector cells at the tissue sites such as the skin, the joints, the entheses get turned on and lead to the destructive changes that can be seen in the joints and the spine and the changes in the skin. And this is even a more complex figure that gets across the point that upon activation, these cellular receptors for cytokines such as IL-23, IL-17, TNF, then turn on a variety of intracellular signaling pathways that get immune cells to become warrior cells and leads to tissue destruction. There are a number of agents that have been developed over the last almost 3 decades now, which have really revolutionized our ability to take care of patients with psoriasis and psoriatic arthritis. When Alice and Mark and I were beginning our careers as physicians and first seeing patients with psoriasis and psoriatic arthritis, there was very little that we can do other than basically be with the patient as they continue to have manifestations of disease and gradual destructive changes in their joints. The three of us have watched the sea change that has occurred as we've applied our learnings from pathophysiology to then targeting the pathways that are promulgated by cytokines such as TNF, and on this slide, TNF and IL-12, IL-23. There are 5 different TNF inhibitors that are listed here, beginning with etanercept and infliximab in the early days, followed by adalimumab, golimumab, and certolizumab. And to the right, we see the various indications that these TNF inhibitors are now approved for, including not only psoriasis and psoriatic arthritis, but a number of other diseases, including axial spondyloarthritis, inflammatory bowel disease, except for etanercept, awful diseases like hidradenitis suppurativa, juvenile arthritis, rheumatoid arthritis, ulcerative colitis, as examples. And then we move down to ustekinumab, an IL-12 and 23 inhibitor, which is approved for the treatment of psoriasis and psoriatic arthritis, and several other biologic medications, interleukin 17 inhibitors, 23 inhibitors, 36 inhibitor, and CTLA-4 inhibitor. These are all known as biologics, and they're called that because they mimic immunoglobulin molecules that are part of our natural immune system, large proteins that, if given orally, would be destroyed by stomach enzymes. And so they have to be given by either subcutaneous injection or intravenous infusion. The IL-17s noted here either target interleukin 17A, a very prominent pro-inflammatory cytokine alone, or in the case of the newest entrant, bimekizumab, which inhibits both IL-17A and IL-17F to try to give it a little bit broader reach and potentially more effectiveness. And then the interleukin 23 inhibitors, which are noted here, which are given infrequently as subcutaneous injections. For example, risankizumab is given once every 3 months, guselkumab once every 2 months. So it's very convenient for the patient. And one of the features of the IL-23 inhibitors is their really excellent safety profile, which we're going to come to more in a moment. And these, both IL-17 inhibitors and the IL-23 inhibitors are very effective in the treatment of psoriasis and psoriatic arthritis. When it comes to individualization of treatment, we go through certain thinking processes in our mind whereby we say, well, what does the patient in front of us display? And if the patient has active arthritis, along with active skin and nail disease, and active enthesitis, for example, we can rest assured that all of the treatments that I've just gone through can be effective in those different clinical domains. But let's say the patient has a very active spondylitis condition. We're still in the process of learning how effective the interleukin-23 inhibitors can be for the spine. There's an important study underway with guselkumab to try to ascertain its ability to affect the spine. So that's an example where we might individualize depending upon the patient's manifestations. And then I've also mentioned here an interleukin-36 inhibitor and CTLA-4 inhibitor, abatacept, which is a T-cell modulator, which is approved not only for psoriatic arthritis, but also rheumatoid arthritis, but not psoriasis, because it is not quite as effective in the skin. And then we move over to some medicines which are given orally. First, the Janus kinase inhibitors, or JAK inhibitors, including tofacitinib and upadacitinib, the first being a JAK 1, 2, and 3 inhibitor, the second a JAK 1 and 3 inhibitor, and then the agent deucravacitinib, which is also a member of the JAK kinase family, but it's focused on specifically inhibiting a molecule known as TYK2. And TYK2 is in particular is important in relation to interleukin-23 signaling, as well as interleukin-12 and interferon signaling. So that medication we are targeting for psoriasis, where it's currently approved, and it's en route toward being approved for psoriatic arthritis. And so it's more specific and does not have the broad reach that the other JAK inhibitors do, which not only are approved for psoriatic arthritis, not psoriasis, they haven't gone for that particular indication, but also a number of other diseases, including rheumatoid arthritis and inflammatory bowel disease. And then there's the medication apremilast, which is a PDE4 inhibitor. This works again by inhibiting certain intracellular signals in inflammatory cells to have them not be so inflammatory. This medicine is given as a twice-a-day oral medication, which has efficacy and approval in psoriasis and psoriatic arthritis. Can be effective in those conditions. So what the various treatment recommendations for psoriatic arthritis do is they try to identify what are the medicines that have shown good efficacy based on clinical trial data, as well as reasonable safety profile. And they're listed here as being able to treat the different clinical domains or not. And so you'll notice, for example, that in peripheral arthritis treatment, virtually all of the medicines that I've just gone through, including some of the older drugs such as methotrexate, sulfasalazine, and leflunomide, can all be effective in peripheral arthritis. And so based on the clinician's judgment about the relative effectiveness of the drug and relative safety, applied to this particular patient in front of them and their particular choices. Do they want a medicine that's given orally or subcutaneously or possibly intravenously? These are all factors that go into the decision making. And virtually every drug that I've just spoken about is effective in this clinical domain. If we move over to axial disease, we see fewer of these drugs having shown efficacy. TNF, IL-17 inhibition, and JAK inhibition all show good effect in the spine, but others maybe not so. And as I mentioned, we're still in the process of learning whether interleukin-23 inhibitors may do so. If the patient has a prominent Achilles tendon insertion enthesitis and has to wear an orthopedic boot, even if their peripheral arthritis is well treated, this can be a big issue. And again, most of the drugs that we have just discussed can be effective in this domain. Dactylitis, psoriasis, nail disease. And then in addition, we have to think about what drugs might be effective for associated conditions like inflammatory bowel disease or uveitis as we're making our choices. For example, we have learned that etanercept is not so effective in treating IBD or uveitis, so we'd probably not choose that as a TNF inhibitor, whereas we might choose any of the others. One of the issues that we all face as clinicians treating immune-mediated inflammatory diseases is that with time, these medicines may wear off in their effectiveness. Either the patient may not have a good response initially after a few weeks to months of treatment, or the patient may have a good response, and then a year or 2 or 3 later, we may see gradual loss of response. The former is called primary non-response, the latter is called secondary non-response. And so to deal with this, we then end up choosing either another medication within the same mechanism of action or moving to a different mechanism of action. And fortunately, we have choices. We have enough medications that have now shown effectiveness that we can move to a second, third, fourth medication. And many of us, and I'm sure Alice and Mark deal with this all the time, are spending our time working with patients who have tried multiple medications. And so we're having to be creative about either intensifying the medication treatment or even off-label use, doing combinations of medications. And some of the clinical trials coming forward are testing some of these methods of treatment of the difficult to treat, more refractory patients. I've mentioned safety and on a number of occasions here, and this is very important. So this is from the GRAPPA treatment recommendations, in which various of our medications are noted, and if there are particular safety issues related to that potentially related to their use, then we need to inform the patient about this and potentially steer them away if this is going to be a big issue. Here's an example. If the patient happens to be obese and has underlying fatty liver disease and has elevated liver transaminases, then it may not be the best thing to choose methotrexate as a treatment, or one of the other medicines, such as one of the JAK inhibitors that may have hepatic consequences with elevation of liver transaminases. Or if the patient has inflammatory bowel disease as an associated condition, we've learned that there can be a potential reoccurrence or flare of inflammatory bowel disease, or even new onset inflammatory bowel disease with one of the interleukin-17 inhibitors. With the TNF inhibitors, there are a small number of issues, including patients with severe congestive heart failure may have worsening of CHF. If the patient has a potential for multiple sclerosis, that can be a rare side effect of TNF inhibition. And with all of these medications, we need to be aware of the potential for infection. For example, serious infection occurring with TNF inhibitors, a little bit more so than some of the newer mechanisms, such as interleukin 17 or interleukin 23 inhibitors. And a small risk for depression or even potentially suicidal ideation. This is an issue that we need to be aware of because patients with psoriasis and psoriatic arthritis may have a proclivity for this particular comorbidity, and we need to be cautious with certain medicines such as PDE4 inhibitors. Of course, one of the key goals that we have now in treatment of patients with psoriasis and psoriatic arthritis is what we call treating to target. This means that we now are able to get a patient into a state of even remission where they don't have signs and symptoms of active disease or low disease activity, where there's just a minimal amount of disease activity. And here's an example of a criteria that we have developed in the GRAPPA group, known as minimal disease activity. And if the patient has achieved 5 of these 7 thresholds, say, for example, a swollen joint count of less than or equal to 1, or an enthesial insertion site tenderness of less than or equal to 1. If 5 of these are met, then they're in a state of minimal disease activity. And we've learned that that's correlated with all kinds of good outcomes, including inhibition of radiographic damage, better work productivity, better overall quality of life and function. And so we're now able to get to this really good place with many of our patients, and albeit with the need oftentimes to cycle through various medications, are able to keep patients there. So with that, thank you for your attention. I want to turn to my colleagues and just get their observations about what it has been like for them to have witnessed this whole sea change in our ability to care for our patients with psoriasis and psoriatic arthritis.
I guess I'll comment on that. I also am old enough to have seen waiting rooms in rheumatology practices with all kinds of canes and chairs, basically for people who are so crippled they couldn't even sit in a waiting room in a regular chair. And that totally has changed if you look at a waiting room in a rheumatology practice. And that's due to these drugs. And I'll point out that my own mother of blessed memory was a beneficiary. She had psoriasis and psoriatic arthritis and was helped greatly by one of the drugs I helped develop, and which Philip played a major role in too. So thank you, Philip.
I will echo that. Alice and I were high school classmates, so we're the same age approximately, and even though she looks a lot younger. And I will say that I remember going to Psoriasis Foundation patient meetings, and the patients were angry because there was so little we could do for them, and they were simply angry. And people would come in on crutches and in wheelchairs, and several years later, only a few years later, that all changed. There were no wheelchairs. There was not scale all over. Nobody had visible psoriasis. There were no crutches. And it was like a party. Instead of complaining about their doctors and the care that didn't make them better, they were now thrilled to have something that got rid of their pain and cleared their skin.
Thank you again for joining us for this segment on personalized treatment strategies for psoriasis and psoriatic arthritis. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACPE credit, access supplemental slides, as well as other topic segments and case scenarios.